Good morning, everyone. Welcome to Central Jersey Family Health Consortium's webinar series focusing on maternal health awareness in New Jersey. This presentation is one of 4 this week, and all recordings will be available next week for viewing. Today's presentation is post-birth warning signs education, not just a checklist. I'd like to introduce our speaker today, Dr. Trish Suplee. Dr. Patricia D. Suplee, PhD, RNCOB, FAAN, is the Director of Professional Education and Research. She is also an Associate Professor at Rutgers University School of Nursing, Camden. As a seasoned researcher, scholar, and educator, Dr. Suplee's career has focused on improving women's health. Currently, her work focuses on improving maternal outcomes, translating evidence into clinical practice, especially during the postpartum period. Her collaborative work as co-principal investigator on AWHONN's Empowering Women to Obtain Needed Care project led to the development of post-birth educational tools that have received national attention. These tools are being incorporated into postpartum discharge teaching throughout the United States and have been cited as an exemplar by the CDC, HRSA, and the Joint Commission. Due to her expertise, Dr. Suplee was appointed to an interdisciplinary national committee that developed 2 AIM patient safety bundles that are currently used as best postpartum care practice models. She was also a member of the Health and Human Services Office of Minority Health Think Cultural Health team to advise the development of an e-learning program for physicians, nurses, and healthcare providers about culturally and linguistically appropriate services in maternal child health care. She is chair of New Jersey AWHONN and is a member of the New Jersey Maternal Mortality Review Team that analyzes cases, identifies gaps in care, and makes recommendations to decrease maternal mortality rates. Dr. Suplee publishes and presents nationally, is a reviewer for several journals, and has mentored numerous faculty, colleagues, clinicians, and students over the past 3 decades. As you watch the presentation today, please feel free to put any questions you have for Dr. Suplee in the chat, and we'll address as many questions as possible at the conclusion of the program. Thank you, and welcome, Dr. Suplee.
Thank you so much, Kathy, for that introduction. Thank you all for joining us today. Again, I'm going to present post-birth warning signs education, not just a checklist. So just as far as objectives go, I'm going to briefly discuss the current rates, leading causes, disparities, and timing of maternal mortality as a little bit of a review, identify postpartum complications captured in hospital readmission rates, examine your role in providing comprehensive care and education to women during the 4th trimester, integrate AWHONN's post-birth warning signs into post-birth discharge teaching using the teach-back method, and then summarize how we can collaborate with others and utilize this information to improve postpartum maternal outcomes. This is the latest number of pregnancy-related deaths that occur in the first 42 days post-delivery, reported by the National Center for Health Statistics in 2020 for 2018 data. Although the number of deaths reported for 2018 appear to have decreased, this number does not include late maternal deaths that occur between 43 and 365 days. We still do not know if we are capturing all pregnancy-related deaths in each state throughout the United States accurately. We have gotten better with coding and establishing more maternal mortality case reviews. In fact, this is the first time in years that a breakdown of state data has been reported by the CDC. According to their report, only 24 states have numerical data, while the other states' data are suppressed due to confidentiality. Also, this data is for 2018, so we are still 2 years behind, which is not uncommon for reporting of aggregate population data. But what we cannot forget is that this number is still not acceptable. Maternal mortality is a complex problem ranging from how data is reported, how social determinants of health are captured in the reporting, and due to the racial gaps that exist, how we can address implicit bias and structural racism that contributes to these outcomes. We can do better, and we must do better for new moms and their families. I'm now going to go through a quick review of maternal mortality trends, causes, timing, and disparities. Maternal mortality ratios are used to express the ratio of maternal deaths to live births. In the United States, maternal mortality ratios have been on the rise and have remained at an elevated state for several years. The most recent reported rate by the CDC for 2018 data is 17.4 deaths for every 100,000 live births. Here you can see that mortality ratios in the United States have been fairly flat over the past 10 years, albeit higher than other developing nations as reported by the World Health Organization for 2017 maternal mortality ratio estimates. I just want to remind you of a few definitions because sometimes this information gets a little cloudy. Pregnancy-related death is a death of a woman while pregnant or within 1 year of giving birth from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. A maternal mortality ratio is the estimate of the number of maternal deaths to live births. Maternal morbidity is acute or chronic illnesses related to pregnancy. And also you're going to be hearing about a preventability percentile. And that is basically when we look at cases to say, could this death have been prevented? And sometimes when we look at it in committees, we will kind of say, no, it couldn't be prevented versus somewhat could have been prevented or mostly it could have been prevented. And the issue with that is that when we look at that number, when we look at cases, we always can kind of say, well, you know, possibly if this happened, it could have caused a different outcome. So we still continue to dig deeper into preventability. When we look at the leading causes of maternal mortality for the past few years, several medical conditions have topped the list, as you can see here. According to the CDC, the leading causes are cardiac, non-cardiac medical, and infection sepsis. And you can see these percentiles high up here. Around the world, the leading causes are hemorrhage, infection, and hypertensive disorders. So we do differ a bit from comparison to around the world. As reported by the WHO, highlighted here in pink are the conditions or disorders related to cardiac. So again, you can see cardiovascular conditions, cardiomyopathy, hypertensive disorders, which when you add those together account for about 34% of deaths, which is very problematic. And nurses do not always think cardiac conditions when they think of maternal death. I do encourage all of you to become familiar with the leading causes of maternal mortality in your own state, as they may differ significantly compared to what is reported nationally. We are seeing a rise in drug use-related deaths across the country, which may be a topic that many nurses tend to focus little on when providing discharge education. So now let's look at the timing of the deaths. The majority of them do occur in the postpartum period, as you can see here. All pregnant women are at risk for developing a postpartum complication due to the physiological changes that occur with pregnancy. Although the overall risk is small, it is still important for women to hear about it. So if we know the causes and we know the timing, what can we as nurses do to try to improve outcomes? Can we break down what are the most common causes of mortality throughout the postpartum period? And if so, would that help us educate? And the other thing I want to bring up here is even in the state of New Jersey, the majority of deaths occur in the postpartum period. Knowing the actual timing can be helpful when creating interventions and providing preventative measures. Nurses provide the bulk of discharge education and have been doing so for years. But what, when, and how we teach can influence maternity care. So look at this table here, and this was done, this was reported out of 2019 in a Vital Statistics article for you. During pregnancy, what most women die of, again, non-cardiovascular conditions. So again, you might come into place here with regards to earlier deaths related to potential loss or abortions, for example, may be captured in here, cardiovascular conditions, infection. But look at what happens when we switch to the delivery day. We get back into hemorrhage, amniotic fluid embolism, and still cardiovascular conditions. The first week home, hemorrhage, hypertension, infection. So again, that first week home, these are the things that we're most likely seeing when we talk about maternal mortality. And then when we get out to the first 6 weeks, so to speak, before they even return for their postpartum visit, infection, cardiovascular, cerebrovascular accidents, which have been on the rise. And then you could see again cardiovascular disease driving the 43 days to 365 days out. So again, just because cardiac conditions are the leading cause of death, it does not mean that you don't have to discuss bleeding, hypertension, and infection, because it's still problematic. Nurses are usually the last provider the new mother sees and hears from before she leaves the hospital or birth center. She may not hear from another provider until her scheduled checkup, which is sometimes 4 to 6 weeks away. So what you teach is extremely important. Although ACOG has suggested that all women should be contacted within the first 3 weeks of delivery, followed by a more thorough assessment later in the postpartum period, this practice has not been initiated nationwide. The U.S. has also taken the lead on following women out for 1 year post-delivery compared to the traditional 42 days, as reported by other countries when presenting maternal mortality findings. This timeframe has provided clinicians with valuable information that can be useful in providing interconception care and follow-up care for those who are at risk. So we have discussed maternal mortality ratios, timing, and causes, but another clear statistic that is vital to this discussion is the racial and ethnic gap that exists in our country. As you can see from this figure, Black women are 2 to 3 times more likely to die than their white counterparts. It is important for nurses to be aware of this statistic and get involved in their states to identify what can be done to improve these rates. For some of you might have heard New Jersey Nurture campaign kick off this week by Tammy Murphy, the First Lady. She has included racial disparities in her maternity care as a top priority. So again, I would encourage you to visit some of the other information that was pushed out this week for Maternal Health Awareness Week. So let me get into a little bit about hospital readmissions, because usually nurses in the hospital don't necessarily pay attention to them because you may never see the patient again be readmitted. They are usually readmitted to medical floors or GYN floors. But this is a good summary for you. When we look at the CLAP and others and colleagues, they reviewed cases of postpartum readmission for the first 6 weeks after delivery in California, Florida, and New York over an 8-year time span. They found that 2.16% of all deliveries were readmitted, roughly 115,000 women. The most common indication for readmission was infection, followed by hypertension issues and then psychiatric issues. Most of these readmissions occurred on average 7 days after delivery. So once again, that first week home. Nassib and colleagues in 2018 looked at readmissions as a quality indicator. This was done at one hospital where readmissions were reviewed over a 17-month period of time with a 1.55% readmission rate. Hypertensive disorders were responsible for 42% and wound complications 18%. And another one was by Wen and colleagues in 2020. What they looked at was fragmentation of care, which is really important to think of. They used the National Database of Readmissions between 2010 and 2014 and found that 15% of readmissions occurred in hospitals that were not the original birthing hospital. These researchers found that those women admitted were more at risk for severe maternal morbidity and increased length of stay. And I want to point this article out to you because so many times we don't talk to the woman about returning to the same hospital that she received care, where maybe you have access to records, versus her showing up in an emergency room in a non-delivering hospital where they have no records of her. So when I start to talk about the post-birth warning signs, we really do encourage moms to tell the provider, I had a baby on, or I had a baby a week ago. Be very forefront with that information, because it really helps guide the care when it's especially a provider who doesn't know the woman. The other little picture I have on here is a picture of a C-section incision. And why I put that up here is because so many times women don't necessarily look at their incision before they go home. And this should be part of your assessment with her, is to actually show her the incision, what it looks like, and also explain to her what it might look like if it was to get infected. And we'll talk a little bit about that when I go into wound care. We really do know a lot about best practices in postpartum education, as can be seen here by all of the topics you teach during and after birth. It's really hard to rank what is the most important topic, isn't it? And in one study they did, they looked at a comparison of differences between what the nurses thought was the most important and what the moms thought was the most important. And as you can imagine, they differed. In addition, if you ask nurses and patients, they too would have different opinions, basically because their concerns are different. So don't always assume that your main concern is the patient's main concern. But again, it's really important that you hear the patient's main concern. Even if you think it's not high on the list, it's high on her list, so it's important to address. And in fact, I would encourage you to address that one first. Because if you remember when you were all students back in the day, if you were in the classroom and you had a question and the instructor said, you know what, I'm not going to take the questions till the end. A lot of times what would happen is you would keep focusing on that question in your head and not pay attention to everything else that was being presented. So I encourage you to do the same, because the mom needs to release herself of that question so she can then continue to listen to the information you provide. So what we have to do is to make sure new mothers receive all of the education they need to care for themselves and their infants, but not make it all about the infant. Maternal self-care is as important, and women need to hear that from you. She needs to hear that she too is important during this transition. The other thing is all mothers should have a voice in their postpartum plan. She should be able to identify her support system, her postpartum care team, including providers and community partners. This is your responsibility as a nurse to get her this information. So again, it has to be literacy appropriate and also language appropriate. It's also important to provide education in front of a support person. Asking a woman where she is going post-discharge is important, as many women may not be going home, but may be going to a family member's home or to a shelter. If this is the case, additional information and questioning may be warranted. In one study I did in Camden, New Jersey, we found that several women were not discharged home. They were discharged to shelters and never told anybody, because they were embarrassed or they thought that their children would be taken away. So again, really try to understand where they are going, because they may need different information. And finally, the importance of returning for her postpartum follow-up appointment should be stressed. So new mothers need to learn about potential warning signs. And I keep this ball out of the circle because I don't necessarily know where you may want to address it. And why I say that to you is that I need you to address it with the patient at the right time. So use that to know that you obviously can start educating the patient the minute she shows up on your unit, but also it needs to be repeated during her hospital stay. This information is not to scare them, nor do they need to hear a lengthy discussion about mortality, but it is our role to empower them with tools, in this case, education, which includes what to look for and what to report to their provider so they can be seen in a timely fashion. I want to stress here the importance of giving women a voice in their care. So again, you might have heard me talk about post-birth warning signs already. I'm just going to go over a brief background for those of you who haven't. Basically, this program was technically born as a tool. It first started as a quality improvement project funded by Merck for Mothers to AWON, where Dr. Deborah Bingham and myself led the project, and we started with nurses. We wanted to hear directly from you what you were teaching, how you were teaching it, who you were teaching it to, and any information that could assist us with our project. We interviewed nurses from 6 hospitals across 2 states, and what we found most often, that the focus of the teaching was usually on the baby, and that information and level of information varied not only between hospitals, but within the same staff. So what I'm saying by that is, even when we were sitting around a table doing focus groups, nurses were sharing different educational experiences and what they taught, And many people would sit around the table and say, well, I never thought about that, or I didn't teach that. So it really was a very good learning experience. There were several aha moments for staff with regards to their different teaching methods and what information they provided on similar topics. So again, just an example, I asked them about bleeding. What do you tell a woman about bleeding? Well, I heard, well, have her call her provider if she has any excessive bleeding. If they have a lot of bleeding, they should go to the emergency room. If they pass a clot larger than an orange, a golf ball, a pear, a plum, or had a handful of clots, they should notify their provider. What did all this mean? And more importantly, what did it mean to the new mom? What does excessive mean? What is a lot? An orange? Think of how confusing this can be to someone who does not measure QBL on a daily basis or is familiar with how much blood or a peri-pad can actually hold. What we ultimately realized is that before we focused on messages to new moms, we had to focus on consistency of education provided by the nurses. After coming up with our A1s tool and having a panel of maternal experts provide their comments, we then went back to the hospitals to see what the nurses thought. We received an overall positive response, and they were very satisfied with using the tool with their new mothers. Nurses used the tools when they taught women about what to assess for, some using paper handouts while others built them into their EMR. We also started and continue to hear stories about women who have returned to their provider or to the ER with tool in hand, reporting something that they learned about and were encouraged to tell someone. The tool is not comprehensive. It is a review of certain or potential complications that can occur, but we encourage all nurses to begin the conversation with the woman's own risk factors and then to focus on each letter and what it stands for. It also is not to be used, and it was not designated to be used as a checklist, but as a tool for teaching and to help guide your teaching. So please remember, checklists are really a list of things that I did it, I did it, I did it, I did it, I did it. This is not about an I did it. This is about, was it taught and did the woman truly understand what you were teaching? So again, reinforce at multiple touch points, and we're also going to teach them what to look for, what it could mean, what to do with the information. The A1 post-birth warning sign tool is being used around the country by nurses and patients. This tool can be found on A1's website, and you can also contact A1 to use within your own organizations. It's been translated into 4 different languages, with more to come next year. In addition to these paper tools, we also have a campaign going now where we have posters. So we have posters in English and Spanish in New Jersey. So again, if you would like those posters, please just email me and I will get them out to you. You can hang them on your units. You can hang them on bathroom walls. That's a great place for women to actually, read these things while they're sitting. And again, please contact us if you're interested. We also have a campaign going right now to educate all pediatric providers, and you will start to see these posters in pediatric offices and clinics as well. So I want to break this down a little bit more for you so you understand how we designed this. The top is, there's an example of how you can open up the phrase when teaching the patient. We divided it into when you would call 911 versus when you would call your healthcare provider, because we wanted to make it very distinct. The other thing is we wanted to make the reading level appropriate. Now, again, if any of you are involved in any type of literacy, you know that certain words are going to bring up your literacy level. So the further down you go, the higher the literacy gets, because we also wanted to give the woman the chance to truly understand what we were talking about. So again, you'll see that, for example, pain in chest, obstructed breathing, or shortness of breath may mean you have a blood clot in your lung or a heart problem. Seizures may mean you have a condition called Preeclampsia. We wanted to start putting those words out there for the woman, so when she heard them, if she was in the hospital, she would be a little more familiar with them. The other thing you're seeing on here is a bullet that says trust your instincts. I can't tell you how many times we have to reinforce this into women. I have heard from several women that, you know what, I was afraid to speak up. I didn't want to bother anybody. I didn't want to be that patient. I want them to be that patient because you know what, sometimes what they feel gets ignored and we really have to not do that anymore. So again, I gave birth on, and I am having what? I gave birth on December 29th, and I am having severe leg pain. Okay, give them that phrase. We like them to put their healthcare provider number right on this form. The hospital closest to me is, and a phone number. So many hospitals are using this form throughout the state of New Jersey. And also what's happening is they're giving the woman the form. They are also giving them magnets. Again, you could purchase the magnets from Avon to put on a refrigerator. We encourage the woman to put this right on a prominent place in their home. We also want to have them take a picture of it on their phone before they leave the hospital. So again, we want it embedded in them. You're also going to see the bullets to the right. Trust your instincts. Tell someone you deserve to be heard. And again, the you deserve to be heard, I want you to get that in your vocabulary for each woman. You deserve to be heard. So we're going to break this down a little bit with regards to teaching and what to look for when we talk about post-birth. So we're going to go through each letter right now. P, pain in chest. Physiologically, just a little quick review, normal cardiac output and stroke volume increased by 60 to 70% after delivery. Within 1 hour postpartum, cardiac output returns to pre-labor levels. Cardiac output returns to the person's normal within 6 to 8 weeks. Vital signs, blood pressure may rise slightly, then return to pre-pregnant value in a few days. Pulse, slightly decreased in heart rate during the first 2 weeks, and then to the own person's normal heart rate. And then trending changes should be observed and reported. So again, that's obviously not something the patient may be doing, but as a practitioner, that would be something we look at. When we talk about cardiovascular disease in pregnancy, it's the leading cause, as you've heard me say here before. And many times the vital signs are first clue to cardiovascular changes that require further assessment. Chest pain is not normal post-birth. Chest pain can be related to angina or possibly a pulmonary embolism. Cardiomyopathy is a new onset heart failure whereby patients may complain of shortness of breath, cough, or pedal edema. This can be genetic or acquired. Risk factors, previous cardiac conditions, even something like hypertension, arrhythmias, use of cocaine, valvular disease, family history of cardiac disease, obesity, smoking, a lot of contributing factors here to cardiac. What do we teach? Shortness of breath, difficulty breathing, heart palpitations like your heart is racing, or chest pain or pressure, call 911 or go to the hospital. O, obstructive breathing. And again, we're basically focusing on the shortness of breath again. Post-birth, an immediate decrease in intra-abdominal pressure occurs, and the respiratory system returns to the pre-pregnancy state. Normal respiratory rate postpartum is between 16 and 24. And I have to tell you here, I have taught for years, I've been a nurse for years. So many times when you review charts, you will see that the respiratory rate was 18, 18, 18, 18, 18, 18, 18. You know what? Our respiratory rate does change. And again, I would just say to you, please be cognizant of really observing that rate, because sometimes it's the subtle rate in respiratory that we don't pick up on because we're not paying attention. Normal levels of oxygen saturation should be between 95 to 100%. If a woman complains about shortness of breath, a full respiratory exam is warranted. Observe the breathing, listen to her lungs in all fields, assess a pulse ox. Ask her if she is having pain on inspiration or expiration. If she calls in to your unit complaining of shortness of breath post-discharge from the hospital, have her come in to be seen. She could be experiencing a pulmonary embolism, so needs to be evaluated immediately. The most common symptoms of PE are tachypnea and tachycardia. Risk factors for PE: prolonged bed rest, surgery. So again, we have a 3% of our women get cesarean sections, and also hypercoagulopathies of pregnancy can also contribute to embolism. So what we teach: shortness of breath at rest, chest pain that worsens with coughing, changes in level of consciousness. Okay, great. Let's go on to the next two letters. S is for seizures. It is not normal for a woman to experience a seizure after she delivers. Pathophysiology: they can be a sign of eclampsia, or a person may have a seizure disorder such as epilepsy. I must caution you here. People still think that preeclampsia goes away with delivery. And again, you need to get that out of your head. Okay, people can still develop preeclampsia and eclampsia in the postpartum period and never have experienced or shown signs during the intrapartum period or hospitalization. So please, please know, if a woman calls in complaining, and again, preeclampsia signs and symptoms, tell her to be seen. Risk factors here: history of preeclampsia or seizure disorders. If a person calls in, is having a seizure, and again, most likely it wouldn't be the person calling in, it would be somebody else, tell them to call 911 immediately. Stay with the person, position the person to the side to prevent aspiration, and focus on safety at this point in time. Have the person lay down gently to the floor, and again, like we would do in the hospital. Thoughts of hurting self or even others. Although this category is not on the top of the list for pregnancy-related deaths, we felt it was really important to add to this warning sign sheet due to the potential for tragic outcomes. It is not normal for a woman to want to hurt herself after giving birth. Postpartum blues is very common, and major depressive disorder with peripartum onset is the official diagnosis of PPD, or postpartum depression, which we were really talking about perinatal mood disorders for them. Several factors can contribute to postpartum psychiatric disorders, such as psychosocial factors, neuroimmune factors, hormonal alterations, genetics, and sleep alterations. Risk factors: previous history of PPD with past pregnancies, history of depression, anxiety, psychiatric illnesses, low social support, or even stressful life events. So again, just for a basic phrase here, if you have thoughts of hurting yourself or others, call 911 or go to the hospital immediately. On to birth. B is bleeding or hemorrhage. Normal blood loss physiologically, about 500 cc's or less for the vaginal delivery and 1,000 cc's for a C-section. It really is important to measure QBL to aid in this assessment, and I know many of you are doing that already. Pathologically, excessive bleeding needs to be assessed and treated quickly. Bleeding is most often related to uterine atony, but can be related to lacerations, retained placenta, DIC, and infection. Risk factors: multiparity, overuse of Pitocin, and even a history of coagulopathy. So what do we teach? Assess for the amount of blood loss. Describe the amount that is concerning. For example, has the woman saturated one pad or peripad within an hour? Is she passing clots larger than an egg? Ask about feeling lightheaded or dizzy. And we came up with an egg as a universal sign because around the world, almost every woman would probably know what an egg looks like versus using different fruits and golf balls and etc. And again, call the provider at this point in time. Incision that is not healing, and I started talking about this a little bit earlier. Whether a woman has a C-section, repair of episiotomy or tears, these are all wounds that require assessment. Wounds should be assessed for redness, ecchymosis, edema, discharge, and approximation. So again, these are things you can teach the woman while you are doing your education. Show her what that incision looks like. Get a mirror before she leaves and show her her perineum. You know, the other thing is with telehealth, we are also encouraging pictures. And I know that sounds a little odd, but the fact of the matter is you can see a picture. You can assess a picture. Risk factors, obesity, and infection. And the other thing I want to say with regards to infection with the actual wound, many women have a canis who are overweight or obese. So they really need to pick up that fat layer and look at the incision and keep that dry. So again, take a shower and then dry that area off, and maybe even put a dry peri pad in there so to decrease the sweat that might occur that can contribute to infection. But make sure she knows to keep that area dry. What we teach: assess wound daily for the signs and symptoms of infection, such as wound drainage, redness or swelling, or separation of the incision. And she needs to be told to call the provider if she notices any of these. Okay, R, red or swollen leg, again, sign of deep vein thrombosis. There is an increase in fibrinogen and clotting factors during pregnancy, as well as an increase in venous stasis, which may lead to an increase in thrombus formation. So therefore, all women are at risk for deep vein thrombosis just because she has had a baby. And again, a release of a thrombus can lead to a pulmonary embolus. So again, a clot traveling to her lung. Risk factors: multiparity, obesity again, assisted vaginal birth, immobility, advanced maternal age, and having a C-section. So what do we do here? We teach her what to look for. Again, we kind of focus around the calf area because that's, again, where we tend to see or the woman complains of tenderness, the calf area of a leg, swelling of a leg more than the other, and even warmth of the leg. So again, I would put her hand on her calf and actually tell her this is the area we're looking for. Temperature above 100.4. There may be some elevation of temp in the postpartum period related to dehydration. However, a temperature above 100.4 is used as a guide for further assessment and treatment. Pathophysiology could be related to a wound infection following C-section, mastitis, UTIs, and endometritis. So wound infection isn't the only infection that women show up with when they get rehospitalized for postpartum care. So just keep that in mind too. It's not always about the wound. They could get infections in other places. Risk factors: if the mom experienced chorioamnionitis, prolonged rupture of membranes, had any type of vaginal repairs, obesity, and also surgery. We encourage moms to take her temperature if she feels like she's starting to feel a temperature, and again, report 100.4 or higher. Okay, we are on the home stretch. We're on the mighty, mighty, mighty H, and I can't reinforce enough how important this H is. Headache is not a normal finding in the postpartum period. Headache may be related to hypertensive disorders of pregnancy, especially preeclampsia, or it can be a migraine headache. It could also be a headache related to dehydration. Again, women get headaches. I'm not saying that they don't. But it is important for nurses to know that women can develop preeclampsia, like I've said before. The severity of the headache needs to be assessed, which can be done using a rating scale. Again, on a scale of 0 to 5, 0 to 10, where would you rate this headache? Mild headaches may be the result of dehydration or stress. However, it is very concerning when a woman complains about a severe headache or states, "This is the worst headache of my life." And we hear that statement in the ERs. This is the worst headache of my life. That should be an immediate trigger for this woman to go get help. Risk factors: a history of preeclampsia or hypertension or even migraines. What we teach: headache, location, duration, intensity. And again, she should be assessed immediately. Now, although comorbidities are not part of the post-birth warning signs tool, I also want to remember or remind you that comorbidities are important to bring up. And here you see bullets on mental health, drug use, and other medical conditions, because all of these contribute to maternal morbidity and mortality. And we know across the country we are seeing more deaths related to drug use. So don't think that it's not your job to address these. It is your job to address these and to get women connected to care and services after she's delivered, and also even into the community. The other thing is, if a woman has a history of drug use, it's really vital that we start working with our pharmacies and working with our providers to make sure if she has an addiction to opioids, she is going home with a naloxone prescription. Wow, I've told you a lot. So we are going to switch gears. So again, I thank you for your patience in that, but I think it was important to go through. So let's switch gears a little bit, and we're going to target what is your role in improving maternal outcomes. And what you kind of see here is I want you to start with yourself. Self-awareness, equity, social influences and competencies. I want you to ask yourself, are you confident in giving all this information? Because if you're not, I want you to seek out more education. I want you to integrate EBP resources into your practice, which I know you do all the time. And I also want you to elevate the use of cuss words. And again, I know you are familiar with the cuss words here because I've heard nurses talk about them. For those of you not familiar, you probably have heard of SPAR reporting, SBAR, for when you want to report or give off a handoff. But cuss words can also be used, and both were developed by the Agency for Healthcare Research and Quality. CUS stands for concerned, uncomfortable, safety. So let me give you an example. I'm concerned about our patient, Mrs. Schelt. Her blood pressure has not decreased since our last conversation. She's also experiencing a frontal headache. I'm uncomfortable with her clinical picture at this time. Can you come evaluate her? I believe this is a safety issue. Now again, you would utilize that conversation if you felt your voice wasn't being heard and you really wanted to focus that provider on your concern, okay? So again, just another example of what you can do here. Teach women and their significant other during every exchange. Well, we've been doing that as nurses for as long as we can remember. Provide consistent messages to all women, but individualize their care to each woman. I also want to reinforce the Stop, Look, Listen campaign. For those of you who have heard some of the information this week, Robin Dioria really spoke of the Stop, Look, and Listen campaign coming out of the Tara Hansen Foundation yesterday. I want you to stop. The minute the woman asks you a question or has a concern, I want you to stop. I want you to look the woman in the face, and I want you to listen. Because so many times we hear a question and we immediately want to answer that question without allowing the woman to really talk about what she's feeling. So again, I really want you to start pausing before you answer. And the other thing is to reassess when your role ends. So again, when I started talking about getting them connected to the community, getting them connected to the providers, making sure they have their postpartum appointment before they go home, that is your job. So we are going to turn our heads now to education. There are barriers and facilitators to patient education, and I'm sure these are not, I'm sure you've heard these before. Barriers can be the educational level themselves, as well as literacy. So we do need to assess this, and sometimes you just get this through communication, but you can also get it by sharing information and asking the patient to read it back. Physical environment. How you set up that physical environment for teaching is extremely important. There's been some research done actually listening to these exchanges going on of patient education. The TV's on, the person's on their phone, the significant other is yelling in the room, the nurses are making announcements on the loudspeaker, the door is wide open, the janitor, the assistant is in cleaning the bathroom. Again, we have to set that environment for the best environment to provide patient education. Language is important. I can't tell you how many times I hear that women do not have educational information in their own language. So think about this. Think about you being in the hospital and somebody handing you information in a language that you don't speak, or handing it to your significant other. it basically means nothing. And yet you're going to check off on the list that it was done. It's very problematic. I know those language lines are hard to use, but it's really important. Timing, we start from the day of admission to the time the person leaves. So again, your timing is going to be important. And it's also going to be the timing of the patient. You know, is it a good time to teach? Because you know what, just to get it in to say you did it, you might as well say you didn't do it if the timing wasn't right. Lack of resources, make sure you have the resources. There are so many resources out there for nurses, and I have a lot of these resources at the end of the presentation. And then perceived awareness. How aware are you with regards to how you teach? So again, it can be a barrier for the patient. On the flip side, facilitators, we want consistent messaging. We want the nurses to be experienced and exposed to this type of information and how to teach. And please remember that in nursing school, students may learn how to teach in like a lab, but they don't get consistent education on teaching or experiences because, again, they're learning depending on what is in front of them. The ability to understand the importance of education is a factor when it comes to a facilitator. Do you feel this information is important? Because if you don't, it's going to come off and the patient is going to pick up on that. Decreasing the environmental stimuli, how can we do that? Ask the patient, may I turn off your TV? You know what, do you mind putting your phone down? I'd really like to talk to you about something. Close the door. Hang a sign on the door saying teaching in progress, please do not enter, okay? And then if you can possibly have a support person listening too, we do know that the support person does listen. Some teaching basics, you want to assess the readiness to learn and learning style. If you think about it, not everybody learns the same. So some people like to hear information, some people like to see it, some people like to demonstrate it or have a combination of them. So it is important to kind of learn what your patient's best style is. What's the appropriate moment for teaching? Previous knowledge, don't assume, okay? We tend to assume as nurses, well, she's had another baby before, she should know that. Or I see this all the time. If the patient is a nurse, a physician, a midwife, etc., they'll say, oh my goodness, I'm embarrassed to teach her because she must know that. And I have to say that happened to me in the hospital when I had my child. People just kind of said, oh, you know this, you know this. Well, you know, the fact of the matter is I might have taught that information, but I didn't learn it as a mother. So again, don't make that assumption. Use appropriate language. So again, it gets back to if you don't speak the language, you need to pull out that language line. Address their concerns first. This is getting back to what I said about that question that you hang on to because you want to ask it. But again, get their concerns out first. And then I want to jump into the teach-back method. Now, the teach-back method has been around probably since about 2015. You have probably heard about the teach-back method, but you might not have been taught how to do it. So again, I want to go through this with you, and I'm also going to have an example for you. Teach-back is a way to make sure the healthcare provider themselves explain the information clearly. It is not a test or a quiz of patients. Asking a patient to explain in their own words what they need to know or do in a caring way. And it's a way to check for understanding and, if needed, re-explain and check again. It's a research-based health literacy intervention that promotes adherence, quality, and patient safety. So there has been research to support this method with very positive results. And I did include some of those articles on the reference list for you. So again, it's really important that you realize it's not a test of the patient's knowledge. It's a test of how well you explain the concept to the patient. You want to plan your approach. Think about how you will ask your patients to teach back the information. So for example, you may say, we covered a lot today. I want to make sure that I explain things clearly. So let's review what I discussed. Can you please describe when you need to call the doctor? Again, an approach. Another approach is a chunk and check. Don't wait until the end of the visit to initiate teach-back. Chunk out the information into smaller segments and you have your patient teach it back. Repeat several times during a visit. So you may even want to chunk out that post-birth warning sign list. You might have chunked out when to go to the hospital, 911, or when to call your provider. And please remember with that post-birth warning signs checklist, you don't have to go in that order. Go with your comfort or go with what you want to group together. Clarify and check again. If the teach-back uncovers a misunderstanding, explain things again using a different approach. Ask patients to teach back again until they are able to correctly describe the information in their own words. If they parrot your words back, they may not have understood. Start slowly and use it consistently. So you may want to first try it out with a colleague, even role play. I know that sounds kind of like, wow, really? But it's important. And then once you're comfortable, try it with a patient. And then you need to practice. Use the show me method when describing how medicines or changing a dose. Research does show that even when patients correctly say when and how much medicine they'll take, many will make mistakes when asked to demonstrate the dose. So you can say something like, I've noticed that many people have trouble remembering how to take their insulin. Can you show me how you're going to take it? And then use handouts. Write key information down to help them remember. Give them the handout. Give them the picture of the handout. Give them the magnet, etc. Now again, there's 10 elements of competency on the right-hand side. I'm not going to read all those out for you, but again, they're there for you. One of the things you want to avoid is asking questions with a simple yes or no answer. You really want to get them into explaining or emphasizing what they've understood. And again, it's something that you can do easily. It does not extend the time. They have looked at that in some research, like, oh my goodness, this is going to add so much more time to my teaching. No, it doesn't. So teach back phrases for post-birth warning signs. I came up with some for you on the right. I want to make sure you are comfortable with what to look for when you get home that may be concerning to your health. I know I just taught you a lot of information. Let's review each one so I can make sure I taught you correctly. After reviewing all of these potential warning signs, can you tell me when you would call your doctor or midwife? Trust your instincts. If you feel that something is wrong, speak up until you are satisfied with your care and you feel safe. And on another one, I want you to know that I care about your health and healing as a new mom. I do have a video here. I'm going to hope that it works. So here we go.
Hi, Jocelyn. I'd like to teach you about some signs you should be aware of that might mean you are having a problem after giving birth. Is this a good time for you?
Yeah, sure. The baby's getting circumcised, so is in the nursery.
Would you mind turning off the TV so we can talk? I also hung a sign on the door so we are not disturbed. I'm going to be talking to you about post-birth warning signs. Have you ever heard about them?
No, I haven't.
Well, most women who give birth recover without any problems. But there are some potential complications that can happen, and I'd like to teach you about them so you know what to look for. Are you okay with that?
Yeah, sure.
The first topic is bleeding. What have you been told so far about vaginal bleeding?
That I'll probably have bleeding for a couple of days, and then it should fade away like a period.
Yes, that's a great start. Usually after a vaginal delivery, women have about 3 to 4 days of bleeding, and then it changes to a pinkish, then whitish discharge over about 10 days. But let's talk about the amount of bleeding. If you saturate or completely fill a peri pad every hour, pass a clot larger than an egg, or if you are passing what looks like a handful of smaller clots, you're bleeding more than we would like you to. If this should happen, we want you to call your doctor and let her know. Also, if you are feeling lightheaded or dizzy, these are important signs too that you might be bleeding too much. Would you mind telling me in your own words when you would call your doctor for bleeding so I know if I was clear?
If I pass a clot larger than an egg, or I completely fill a pad more than 1 an hour, I should call.
Yes, that's correct. Are there any other signs that might mean you are bleeding too much that you might experience?
Oh yeah, if I feel lightheaded or dizzy.
Wonderful. Just remember that if you are feeling lightheaded or dizzy, you should lay down and call for help. Will you have anyone staying with you after you are discharged?
Yes, my boyfriend. We live together.
Good. All new moms need support when they get home. The next topic is shortness of breath. Most women do not have difficulty breathing after they deliver. However, women who have difficulty breathing may be having an issue with their heart or lungs. Have you ever experienced difficulty breathing?
Just when I exercise, I sometimes feel my heart racing and I have to breathe heavier.
Yes, that is what happens when we exercise. Our heart rate goes up and our breathing can be a bit more labored to get more oxygen to our lungs. You shouldn't feel shortness of breath or like you can't catch your breath just by doing normal activities like walking around the house or sitting in a chair. Also, you should not feel any pain in your chest. If these symptoms were to occur, we want you to call 911 or go to the emergency room.
That sounds scary. Does that happen to a lot of women?
No, it doesn't happen a lot. That is why it's important to get help quickly. So can you tell me when you would go to the emergency room or call 911?
If I have problems breathing or chest pain.
Excellent. Let's continue.
I want you to make the experience memorable. The perception of the birthing person. We have to remember this. You must believe in the importance of sharing information if you want her to believe. Your verbal and nonverbal behaviors are really important. I want you to end the experience with a positive reinforcement statement. What do you want the woman to remember about you? And how did you contribute positively to this mother's journey? So these are some examples of what we tend to hear. I only have a few minutes to go over this with you. So what's the perception? I guess she doesn't have time for me. This is your second baby, so you know all this. I really don't know all this, but I guess I should. You don't have any questions, do you? No, I guess not. You can read this information at home. Doesn't seem too important. I guess I don't really need to know it. So again, your phrases are so important to the perception of the woman. Okay? So take the challenge. I want you to ask yourself, who taught you how to teach? How do you best learn? And then I want you to bring it back to your unit. Have all the nurses on your unit received education about maternal morbidity and mortality during the postpartum period? If not, it's important to get that information to them. And this is my challenge to you. Ask a colleague to listen in on your teaching about post-birth warning signs with a patient and have them give you constructive criticism. I want you to focus on not only content, but the presentation. So what are your next steps? Sharing your experiences with each other, collaborating with other departments, and reaching out to community partners. It is really important that we start really trying to expand and exchange our ideas among the partnerships that we have, okay? It is not good to work in silos. So here's some additional information for you with regards to where you can find some excellent information on not only teaching, but also some of the AIMS bundles that have been developed. And also you will see A1 educational webinars, ACOG toolkits. I've also put on there the Teach Back toolkit, which is also available. Has a ton of information on what you can share with your staff, what you can take back, and there's also examples there as well. Here's a reference list for everything I've touched on today. Feel free to use these references. Again, I did include some research on TeachBack on the references for your information. And finally, I want you to thank you for joining today. It is so vital that we continue this work. We are now, again, like I said before, getting it out into the community. We've educated home health workers, community workers, pediatricians, and we still need to get it out. So your voice is important. But please remember, it is not only what we do, but also what we do not do, for which we are accountable. Thank you so much, and I'll take any questions if their time allows.
Hi, Trish, it's Kathy. I don't see any questions in the chat, but I just wanted to thank you for telling us not to assume that the mother knows from prior experiences or that she knows how to take care of herself or her baby because she's a nurse or a physician. or another healthcare provider, because that's so not true. And we really shortchange mothers and fathers if we assume that they have prior knowledge by not assessing what their knowledge is and covering the information. So thank you. And one thing that came up when the nurses that I used to work with, working on the research study on empowering women, was these warning signs can be very scary. And they were nervous about scaring women. So how do you recommend that nurses provide education on these things, very scary things, without frightening them?
Oh, sure. And that came up in our focus groups as well. I think, again, it's how you open the conversation and your tone of voice. So, for example, I want to talk to you today about some potential things that could happen after you get home. I'm not telling this to scare you, but I'm telling you that it's important that you know your body so we can get you help if you are to need it. So once again, it's the level of concern you're showing for the patient herself, but it's also trying to give her the sense of this is important information. And if I was to experience it, I'm hearing I should tell somebody. And that's the link here is I want you to tell someone. I want you to get care. I want you to get assessed. And I think when women hear that, they hear in your voice that you're concerned for them. And it kind of takes it down a notch that it's not about, wow, I have to think about death today. Absolutely not. And that's why we got away from using the term like mortality when we opened up this discussion. We really didn't open up with, I need to talk to you about maternal mortality. That's a medical term. So we really wanted to say, I want to talk to you about potential things that might happen so we can make sure you can get help.
Thank you very much for answering that question. I'm not seeing any questions in the chat, and we are at 12:01. So I think this will be the conclusion of the webinar today.
Great. Well, thank you so much, everyone, for joining.